My name is Nicole Terfloth. I'm a second-year medical student at the University of Tennessee, and myself, along with my colleagues, Emrose, Kathawala, Nolan, Corbitt, Anurag, Epparla, and Emmy, Coleman, all went to Uganda this past summer and spent a global health experiential fellowship there and underwent 6 weeks of research where we explored pathways to mental health care in rural Uganda, the provider attitudes, collaborative challenges, and implications for holistic patient care in terms of people with mental illness, so patients with schizophrenia, depression, episodes of psychosis, and major depressive disorder.
All right, so as Nicole mentioned, our group traveled to Uganda this summer with Empowered Through Health, which runs a health clinic in the Buyende district, which is a rural district in eastern Uganda. And so our project focused on pathways to care for people living with mental illness. In Uganda, there are about 28 psychiatric units, but 68% of the beds, or 60% of the beds, are in Kampala, the capital city, but 87% of the population lives in rural areas. There are about 53 psychiatrists in Uganda, but about 14 million people there are estimated to be living with mental illness. So there is a disproportionate access to biomedical providers, especially for those living in rural areas. And so people in rural areas with mental illness tend to rely on their religious leaders or traditional healers and members of their community for care. And so what we wanted to look at was how can we assess the attitudes towards mental illness and mental health and see the willingness of collaboration between religious leaders, traditional healers, and biomedical providers. And our goal was to be able to establish possible mechanisms for this collaboration so that through a biopsychosocial model to see if we could improve health outcomes for people in Uganda living with mental illness.
Yeah, so as Emrose mentioned, the district that we worked in was Buyende district, and we selected this district because it's very representative of many rural areas in Uganda, and also the program that we worked through, which is Empowered Through Health, they're located in this district. And so because ETH is located in this district, we had a lot of connections already established. And so we were able to work with community leaders and village health teams, which are government institutions in Uganda that are local to the villages that help connect people to providers and different things that they might need when they're in their communities. And so these community leaders and health teams allowed us to connect with many different traditional healers and religious leaders. And then we selected biomedical providers by looking at rosters across different health centers in the area. And so the criteria for being a part of this study was firstly, a person needed to be 18 years or older to participate. And then for traditional healers and religious leaders, we were looking for people who are seeing on average 5 or more patients with mental illness per month for an average of 3 months. And then for biomedical providers, we were looking for people who had completed a secondary school degree with an extra year of schooling, which grants them a certificate in Uganda that allows them to practice.
So in total, we came up with 18 traditional healers to interview 17 biomedical providers and 18 religious leaders. And of these, we went through the process of in-depth interviews and where we asked them to fill out structured questionnaires and then underwent focus group discussions. Those focus group discussions were within that same provider population, and we also had one that was with mixed providers, so with traditional healers, religious leaders, and biomedical providers. In terms of data collection, what we did to gather the attitudes and the responses from providers was 2 research assistants arrived at each location. We worked with Ugandan fellows, so these are students in Uganda or biohealth workers. And at the start of each interview, each provider was read and given a consent form before conducting the interviews. We then asked providers 13 open-ended questions to gather their thoughts on mental illness and stigma. These questions consisted of demographic info, background info, and then yes or no questions or yes or no statements they answered about mental health. And then we then asked those 13 open-ended questions or sorry, 13 open-ended questions, and then that 64 question standard mental attitude and stigma questionnaire. And then the next day, transcription was translated and familiarized by our research assistants, then thematically analyzed. And as those major themes were emerged, results were compiled into tables with relevant quotes illustrating each theme.
So for the results, we looked at 3 groups of mental health care providers: the traditional healers, religious leaders, and biomedical providers. So the traditional healers, they use herbs, counseling, rituals, and will communicate with the spirits to help treat mental illness. They believe that there is a medical cause of mental illness. However, they also think that witchcraft plays a role in mental illness. So this is kind of why they think that their role in treating mental illness is very unique and important, because they deal with the witchcraft side of mental illness, which is why they are a little bit frustrated with biomedical providers, because they want to be more seen in the collaborative model as important, handling that part of mental illness. Uh, the traditional healers do not think religious leaders are able to cure mental illness, because they don't believe in the power of prayer, and they don't really like working with the religious leaders very much. Very hesitant to work with them. The traditional healers do recognize the efficacy and the efficacy of Western medicine and biomedical providers, but they think that they are also just as important as the biomedical providers in treating the patient. They are kind of frustrated again, like I said, because they feel like it's a one-way street, because they'll refer patients to the biomedical providers, but it's usually not the other way around. The religious leaders, they treat mental illness through prayers and counseling. And they believe that mental illness is caused by psychiatric problems, but they also think that it's a part of like God's punishment, which is where the prayers are very important. Religious leaders think that the traditional healers lack the expertise necessary to cure mental illness effectively. They're pretty hesitant to work with the traditional healers as well. Because they believe that the mental illness is partially caused by psychiatric illness. They think that the biomedical providers in Western medicine are very useful in treating. But again, they are frustrated with biomedical providers not using them as much. And they kind of feel the exclusion from the biomedical providers going their way. So in treating mental illness, both the religious leaders and the traditional healers appreciate the role of the biomedical provider, and they wish the biomedical provider will use them more as part of the collaborative model, just more frequently.
Yeah, moving on to biomedical providers, we wish to understand the attitudes and opinions that they had towards other traditional healers and religious leaders, which were probably more cultural and things that have kind of existed in society for a while for many of the people in community, in these communities. And so we've kind of, through our interviews, we kind of understood that biomedical providers in Uganda had a very similar definitional understanding and kind of treatment method when it came to treating people with mental illnesses, very similar to kind of what we see in Western medication, which kind of very much starkly contrasted what traditional healers and religious leaders did, as Nolan kind of explained. In our interviews, we found that biomedical providers typically had more of a negative stigma towards traditional healers. And that was generally rooted in this idea that traditional healers had a misunderstanding of what caused mental illness and how to treat mental illness. And so therefore, many biomedical providers believe that traditional healers oftentimes had crude and very ineffective approaches towards treating people with mental illnesses. They often explain that traditional healers were scammers, or they use words like scamming to describe kind of what traditional healers did. And they also express their hesitancy towards working with them because they believe that traditional healers would sometimes delay opportunity for treatment and medication for people who needed it in a timely manner. Interestingly, there was very little stigma against religious leaders. That was mainly because many of the biomedical providers that we interviewed were religious themselves. So they believed in the power of prayer, but they made a clear point to say that treatment was necessary, therapy was necessary, medication was necessary, but prayer is simply adjunctive. It was there to provide hope for people who need it and who were religious, but it could not stand alone. Despite their hesitancy towards working with other groups, they did recognize that both traditional healers and religious leaders had a very important and culturally ingrained value in these communities. These traditional healers and religious leaders often existed from generations. And so therefore, it's kind of like the go-to for many people who are seeking like healthcare. Another thing that we noted was that like biomedical providers and healthcare facilities was more of like a recent thing. And so there was like very few generally when it came to like rural communities having the ability to access them. So when it came to first line treatment, most people went to traditional healers, most people went to religious leaders. And then when all else failed, they typically went to biomedical providers for medication. And so there's this interesting dynamic where you see that traditional healers and religious leaders are often first line therapy, but biomedical providers, they're kind of last in the referral system, but they're not necessarily devalued. It's just harder to access them. So overall, our study wished to assess the attitudes and opinions of various providers that existed in rural Uganda. Looking forward, we hope that this research serves as a stepping stone for future research that might specifically analyze and develop what this collaborative model amongst these three providers might look like. How could they work together? How could they work through the differences? And what would these like intricacies, like how would solving these intricacies, what would that look like? We also wanted to improve the knowledge of mental health within rural communities, and we wanted to ultimately create better care for these patients. In creating a collaborative model, we hope that we can reduce the disparities that currently exist towards access of treatment for patients who exist in rural communities and have mental health illnesses. That summarizes most of our presentation. Do you have any questions? I think like initially, I think the big thing about these three providers is that oftentimes there's misunderstandings that exist between different groups. Like you come in with different ideas of what mental illness is and how to treat it, and so oftentimes you're gonna have heads butting against each other. So part of like the big thing when it comes to creating collaborative model is being able to provide a platform for people to speak what their ideas are, how they treat, and what like maybe intermeshing these ideas, what that might look like. And so I guess this research was kind of like initially setting up the opportunity for different providers to come in a very collaborative discussive model where they can talk about what they do, what they want, what their goals are, and what maybe a referral pathway might look like. If I can't treat a patient, do I come to you? How can we use our knowledge to create a better treatment plan for these people? So I think the biggest step is like really just being able to provide a platform where people can speak to each other, where to remove that stigma. And then when you have good communication, you can go from there, right? And then Macaulay goes.
Yeah. So in terms of logistics of how that would work, like we said, our research was conducted in Mpunde, in the Buyende district where there is that health center there. And so thinking about next steps, there's an opportunity to work with ETH on creating another research project proposal that we were informed about. And so some sort of research study where we added in all of those providers and we're able to create a program, having everyone that we have talked about involved, and then measuring patient outcomes longitudinally after that could be somewhere where we could go with this research. But like Ani was saying, this is basically the stepping stone that we would then use to create a program that would help, because we first needed to know the data about how to even approach a situation, how to approach rural mental health care. Yeah. That's a great question. And that is something that we noticed. We noticed that a lot of people, I mean, these communities they don't have technology, they don't have access to other areas. And what they really have is word of mouth and stories and anecdotal experiences. And so when you take all these people who have lived in this one area their entire life and you're asking them about what they know about these other type of providers, a lot of them only have these anecdotal experiences. And so when we were able to combine everyone and bring them to an area because we had a car, like a lot of Ugandans don't have a car and they have bikes or they have, I forget, what is the name of the bodas, the motorcycles that they have around there. So when we were able to combine all of these groups together and have them talk to each other, we did find that there was more understanding for each line of work per se. And so like Anu was saying, I think that it is important to have that sort of like platform for them to all talk to each other because they all have their individualized, in a bubble sort of way, that they practice and that they interact with people with mental health. So in summary, um, we did find that there was a more understanding whenever we got all of them together in the focus groups.
And kind of just to add on to that, within the focus groups, there were even times when they were separated, when someone like Nicole was saying, they have anecdotal evidence for the things that they're saying and believe. And so sometimes they would be like, actually, no, like in one of my experiences, this is actually what happened. And what we're saying is actually not like the case. And so what I think Ani was saying, to be able to be together and just have different experiences with working with one another, then I think that can actually start to positively impact their willingness to collaborate with one another.